Hey everyone, welcome back to my channel, and if you're new here, I am Mariana and I interview the brightest minds of physical therapy. So if you want to increase your knowledge, start right now by subscribing to this channel, clicking on the bell so you don't miss anything, give us a thumbs up and share with your friends. Today, our guest is Dr. Joseph Maccio, and he will talk about his study, Directional Preference of the Wrist, a Preliminary Investigation. Dr. Maccio is a physical therapist, holds a diploma in the McKenzie method, and has several MDT-related publications. I hope you enjoy the show. Hi, Dr. Maccio. Welcome to PT Pro Talk. How are you today?
I'm doing great. Thanks for having me.
Awesome. It's great to have you back here. And today we are going to talk about wrist. So just for the ones that haven't heard you before, just tell us a little bit about your background, yourself, and how did you get to where you are right now?
Sure. Yeah, I graduated from physical therapy school in New York in 2008. And worked a couple different places before I worked with my father, who's also an MDT diplomat in Troy, New York, and worked with him for about 10 years when I became certified and then diplomaed. And then since have published multiple studies, mostly focusing on the application of MDT to the periphery. And I guess now I've done quite a few podcasts as well, including one of yours.
Awesome. So if anyone that's listening to us right now haven't heard our previous, just please go back. That was a really good one discussing about his paper. And today we're going to discuss about another paper. So just keep going.
Cool. Yeah. So the study was Directional Preference of the Wrist, a Preliminary Investigation. It was published in 2017. It was my second study. And it was kind of a continuation of my first study, which we're going to talk about, I guess, next week, of the elbow. And we just wanted a larger sample of people. And kind of like I talked about last week, the elbow has always been kind of foreign to me. I see a lot of spine, I see a lot of knees and hips, and shoulders, but as I see I even see a lot of ankles, but I see a lot less elbows and wrists for some reason. I'm not sure why that is or whatever, but so it also is just kind of an interesting joint to me. In my opinion, it's a more dynamic joint. There's a lot of degrees of movement. All the carpal bones sitting on each other have different articulations. So I think that complicates some of the mechanics of it in finding directional preference and just makes it a more interesting joint. And as we get into the study, we found a lot of different loading strategies that were atypical for me. And I think that's partially to do with it, just the complexity of the wrist joint. So we tried to get as many wrist patients as we could in a couple month time frame, just recruiting them our normal business operations. And we also recruited patients through a gym that I was a member of at the time. That was a CrossFit gym, which there's a really high prevalence of wrist extension in that type of workout. People doing push-ups and burpees, handstand push-ups, and power cleans. There's thousands of potential repetitions of wrist extension, which is going to play into what we see in the findings in regards to finding directional preference. So, it was kind of when we did the elbow, it was originally 7 patients, got cut down to 3 for research purposes, and it was still kind of just, it was a time where the research at least was showing that there's much less directional preference in the peripheral joints. And again, that wasn't what I was seeing anecdotally. So I think we just wanted to highlight that mostly because I felt it was going to be way higher than, the numbers on it. In spine, at least at the time, ranged from 60 to 78% of directional preference in spinal conditions. And in The periphery, it was between 2006 and 2012, the prevalence rate increased from 19% to 37%, so the 90% increase. Clearly, it was like something, people are learning it more, they're using it more, they're just applying it in a more effective way. But still, 37% is not what I see, and I thought that was quite low. So that was, I guess, just to see what's out there in a different joint. And then in thinking about the study design and, why that might be, why are people not finding it, right? A complex joint. And we'll get into this a little bit more, I guess, later too. But if you looked at just the research, there was only 2 wrist procedures that were published, at least: wrist extension and ulnar deviation. And in the sample that we had, that would have only equated to 20% of our patients having directional preference. So I think that's really interesting, because if you can find these weird other obscure movements, you would classify them as inconclusive or send them back into the ortho world for Lord knows what could happen. They might be braced for months, they might have surgical intervention, they might have chemical intervention. And yeah, I just think that that's really interesting. So yeah, we looked at all that, and then we wanted to, in thinking about why is this so much less, and is there anything that we can find that makes it easier for people to find directional preference? We looked at 4 different variables and a few other clinical pros that I'll try to touch on as we move forward in the paper. And this was just kind of, I guess, my anecdotal experience and things that I started to see more and think about more, especially as I started to publish research. Previously it was more, I think, for me, just I see a lot of patients, I have good pattern recognition, I have a bunch of things that work, but I didn't really put any numbers on it or statistics on it or try to analyze it in that way. So I think it helped me a lot in being able to more efficiently, at least, predict directional preference in the peripheral joints. So those factors were the same that we did in the extremity, in the similar global extremity paper in the mechanical stress, directional vulnerability, obstructed movement, and painful movement. And then we didn't think at this time, because I don't see a ton of spine referral for the wrist, and I guess it just wasn't on our radar to even account for, but we didn't track the same variables that we did in the other study in the wrist. So we had 2 spines that referred to the wrist, but we just excluded them from the data in regards to the prediction, at least, or in trying to find association with directional preference.
It was interesting that you didn't have that many with spinal SARS, maybe because of the public, like the CrossFit, I don't know, just guessing here. There were more wrist specifics. I would say that probably.
Yeah, I wish I had the Expo study. I'd like to see what their number is in wrist, but what I typically see is that there's less spine referral as you move distally.
Mm-hmm.
So globally in our study, it was around 40. It was over 40%, as it is with the Expo study and a couple other studies. But I wouldn't be surprised if they found a similar thing in wrist, that it was less.
So yeah, wrist was 38%, 38.5
in the Expo study.
Mm-hmm, from spinal
so it wasn't too far off from, I guess, their global rate. What's interesting, I see a lot of people with very apparent spinal referral that, like, I would never classify as a peripheral problem, but they have global, paresthesia in their hand, and they're told they have carpal tunnel or something, even though it doesn't fit that pattern. So a lot of the people in this study were self-referred, but yeah, that was the numbers. I'm not sure exactly why, but 19 people isn't that many people either. So probably if we opened up to a few hundred, that might change it. But anyway, the study was similar to the other one that we talked about. There was multiple people that were used as examiners. At the time, 2 students, and then another student that had worked with me on my elbow paper, that all helped evaluate patients and then just correlate the data and create the study design. and everything. And what was really interesting is they had a lot of freedom in evaluating the patients, and their MDT education was one that never took an MDT course, that had been a student of mine for, I forget how many weeks, but she learned, everything in MDT through me. And then I think another two students that had taken A and B, or one student had taken A and B, and one student that had taken like maybe A to C that had graduated and come back to help on this. So I thought that was a really cool component of it, is the efficacy. There's a lot of people that got better very quickly in this study, and to see students doing that, it was exciting, because when I was a student, I don't ever remember getting anyone better that fast, and never had a really great MDT clinical. But to see how quickly people can learn it, especially before they become biased in other things that they learn, or the application of their PT school to what they learn. I think it's harder to step back. If you teach them early on, they're more inclined, I think, to use it in a more effective way than mix it all kind of together, because they're not confident. So
yeah.
So of the 19 patients, we saw 2 cervical derangements, 15 wrist derangements. There was 1 post-surgical wrist, and 1 person that just failed to sign consent and was just kind of flaky, so they were excluded also. It wasn't bad. 1 person that didn't get to it. The highest correlation of directional preference within the derangement group, which is the only thing that we analyzed, so those 15 people that we looked at, how can we better predict it, was mechanical stress, and that was inversely related to directional preference at 73.3%. The largest was anyone that had excessive mechanical stress of extension. There was a 75% likelihood that some form of flexion was going to help them.
That's a big number.
So a bunch of different forms of flexion, which I thought was cool.
Mm-hmm.
Just passive flexion, a lot with flexion with traction, where they just completely gap the carpals and flexed under traction. And then something which I had used that a lot before, I guess. And then we referred to all these as unloaded or loaded. I don't know if that's technically how the Institute uses it, but we put that in the methodology in regards to weight bearing. So if we loaded a joint through a weight bearing position, we refer to that as loaded, and then some people as partially loaded. But loaded wrist flexion was a new thing for me, and basically we're just trying to use these people that are getting better through flexion. We just want to push it as aggressively as we could under as much load as we could. And that's kind of how that came about. So that was interesting. And then there was one other interesting flexor that needed a lateral glide through the carpals. So it was a medial lateral glide through the carpals as he flexed. So already just through flexion, there was a bunch of interesting loading strategies. But again, I think, from this, to me, the most important thing was that predictor of mechanical stress. If you can on eval tease out what someone does, and if they're doing something excessively with their wrist all day, and you've ruled out the spine. In this study, it was 73%. In the extremity study, it was 90% inverse correlation. So if you can pick that up, you got a good chance of finding the right movement day one before you even move that person. So I think that gives a lot of confidence and efficiency in finding directional preference better. The second highest thing was directional vulnerability at 66%, and that was basically the patient reporting that. So it's very similar to mechanical stress, but just a patient report of it as opposed to teasing that out of them, I guess. But yeah, mechanical stress has always been weighted more, and what I place more importance on when I'm evaluating patients. The things that I thought were interesting about obstructed movement, it was under 50%. And, in a lot of joints I see that's how it works. In neck, people if they have a relevant lateral component, they have a large lateral obstruction usually. In the knee, it's very common that someone has a large obstruction to knee extension. I would say in my anecdotal experience, 80-90% if I identify a loss of extension or hyperextension, that's going to end up being their directional preference. Same thing at the ankle, often at the hip. The shoulder's a little different. His elevation's often most limited and not often directional preference, but when you exclude that, it's commonly that if it's internal that's lost, that's helpful. So to not see that present in the wrist was weird, and to me, because I hadn't thought about it that way. And yeah, I thought it was really interesting. Again, I think it probably goes back to the complexity of the carpal joints, and just there's so many articulations there. Who knows which joint is exactly obstructed? And yeah, it was just an interesting thing. And then the other interesting component of association with directional preference was the patient's most painful movement, which in the wrist was 53% of people's most painful movements. So the absolute worst ended up helping them. And from an educational standpoint, that has helped me a lot, because I didn't used to like to do that, or I wish that it wasn't the most painful movement that was going to end up being the movement that's helpful, because it can just cause an uncomfortable situation with a patient, or a patient less likely to be compliant or willing to participate in what you're asking them to do.
Yeah, absolutely.
Yeah.
We don't want to make them feel worse, and then you're afraid of moving if that's hurting. So it's a good indicator that we should not be afraid of trying the painful movement, because the direction may be there.
Yeah, and I'll often just kind of reference or say, there's a big difference between, temporarily feeling worse and actually getting worse. And, people usually come to me, or healthcare providers, doing a lot of things that might make them feel better, but doesn't actually make them better. And, I'll often say to them, if that was the case, you wouldn't be in my office. You'd be better. So obviously your line of thinking about this isn't effective in fixing this problem. And I think that connects with them a lot. And then using that research, I think, or just an analogy of something being malaligned, if you're trying to realign it and you're in the process of doing that, of course it's going to be painful. Or putting someone's shoulder back into place, you dislocate a shoulder, people can visualize that. It's going to hurt to put it back in position, but if you never do it, it's not going to go back on its own, to my knowledge at least, maybe. But
like lower back, you do flexion, it feels good. It's opening space,
so
helping
people
them.
think that's helpful.
Yes.
And do that all day, and are a year in chronic pain, getting worse. So yeah, those 4 variables I think are really interesting and helpful. Some other things, all the patients that had central symmetrical symptoms responded only to movements in the sagittal plane. And I think in the spine that's understood and talked about, but in the periphery, I've never really heard anyone say that. And
yeah, when I read that, I was like, that's so interesting. I never thought about it. Now I'm going to start paying attention to that movement, start paying attention to the lateral. And I was just talking to you today. I just applied that today with the lateral pain. It worked with extension, with deviation. So I was like, well, I'm going to start paying more attention to see if the pattern repeats. Yeah. Because of what you just wrote. So I was like, that's interesting. It's a good thing to pay attention.
Yeah, absolutely. I've had a lot of people that thought that was really interesting. And after I got all this data, that was like the least interesting thing to me. But I think it's quite relevant because, if you have someone with central symmetrical symptoms, you're probably not going to spend a lot of time moving into lateral, into frontal plane movements or lateral movements. So I think that's helpful. Not set in stone. And if you do have lateral symptoms or unilateral symptoms, you often will respond to a sagittal plane movement also. So I guess I just want that to be said. That wouldn't indicate that you immediately go lateral. That would be kind of similar to most people in the spine have unilateral symptoms, and most people respond to sagittal plane movement. But if that's plateaued, there's the indication to go that way. And then, let's see, 7 people, which, our intent when evaluating these people was to abolish all pain day one, if we could. In my normal practice, and as I got busier as a clinician and felt probably, this was me right after I finished my diploma program, was publishing research, and I wanted to make a name for myself. So I was probably being a little more aggressive in trying to get the best outcome. Where if I'm in the clinic on a normal busy day, if I don't turn someone's pain completely off, it's not that big of a deal to me. But here it led to a lot. It led to more quickly identifying what the most reductive directional preference was and effective directional preference was. And I've heard a lot of people that say, that never happens to me, that all pain turns off day one. But it's possible. And in 7 people out of this 15-person sample, that's exactly what happened. And then there's 8 people that had over a 2-point pain reduction. 10 people had a change of over 50% range of motion. And then 3 people had a change in function. So most people had movement change. I guess all of them had pain change, and 7 had full abolishment of pain. And a lot of those people actually were discharged after visit 2 with no recurrence on longer-term follow-up, which is also pretty wild, because that's, so if you get everything lined up perfectly day one, you find the most reductive movement, you confirm that, you get the education component, compliance in check, and you have a motivated patient, things can really move fast, which is so exciting to see, and to put that on paper is worthy to be talking about on continuing education courses. So I'm going to put that out there. So people should know that.
A lot of good tips in here. People could pay attention to some details.
This paper really had a ton of clinical pearls, which I think is more kind of my what I originally wanted from the study, to be able to give a clinician a lot of information as to my experience and what we've found through seeing thousands of patients. And let's see, of the 15 patients, 5 required a change in directional preference. So it wasn't a ton in the wrist that needed a change in their direction or load. And then 10 of them required no change, and we discharged at visit 2. Some of the other interesting loading strategies, there was a woman that she was a fry cook and was constantly pronating her wrist, and she needed a high velocity whip into supination, or just an aggressive, fast, basically self-manipulation almost of her wrist, which kind of fit that pattern. And there's another older woman that spent a lot of time crocheting with her wrist flexion that needed extension. And then there was, I think, another person that needed pronation with traction. And then the most interesting, I think, loading strategy that we found was supination.
So let me just stop you really quick, ask you a question. Why did you think about the high velocity movement? What made you think about that? Was just like trying experience?
High velocity is something I'll use as a force progression at various joints. Almost self-manipulation. I don't do it often. I don't need it often. But like I had just said, our intention was to find the most reductive movement possible. So, in this person, I didn't write up the case. I have to look back at her chart notes from a long time ago to completely see that. But likely what was happening is she got a response from supination, overpressed it, maybe I mobilized it, did 50 repetitions, must have hit a plateau, and that's just in my realm of force progression. So I think we tried it. In fact, you know what? I think a student suggested it. Actually, I think one of my students suggested it just from that line of thinking. Because I've never done it at the wrist. I've done it at the knee and the hip and the ankle, mostly lower extremity, I guess, and the elbow, but never at the wrist.
That's interesting because we learn about that in thoracic, doing like quick thoracic rotation, but not as much in like extremity. So that's why I thought it was interesting. Like I saw that like high velocity. I was like, that's different.
Well, Mariana, this is why this paper is so interesting and relevant, and we're talking about it, and it's been presented so many different times. Because it's a new frontier, which I think is exciting. Because we talk a little bit about this, like in the bias of why is this prevalence in extremity so low for MDT clinicians? Is it just less? Is it because I predominantly see spine patients, so when I get a wrist, I'm like, what am I supposed to do with this guy? Or I used to be.
Mm-hmm.
Before I reread this paper.
Just give you more ideas of things to try. So I think that's amazing. Yeah. And I was going to ask about, I think you're going to probably talk about in the case, that different strategy that you use to reduce in the end of the case. So I'm curious to hear about that too.
So the high velocity whip was interesting. The loaded wrist flexion was interesting. The flexion under traction probably people have done before. The medial glide reflection was interesting. And then just from that same standpoint of, you could read a large randomized controlled trial or observational trial, get all the stats from it, like the Expos trial. You get more clinical information from that. But a lot of these studies I'll read and I'll go back to the clinic and be like, it didn't make me a better clinician at all. Maybe on the educational end, you might need to reference a study like that, which is equally important. But first, you got to find the right movement. So I wanted this to be small enough that we can really demonstrate a lot of interesting clinical pearls and clinical reasoning. But at 19 patients, that would end up being like 100 pages of a journal article, and they don't let you publish more than 10 usually or so. So we had to figure out, like, how do we get some of that clinical reasoning into this? And I've never seen this done before in a large case series like this. Maybe 3 or 4 patients, you can write up a small amount of what happened. But at this point, JMT was interested in what we were doing. They liked what we were doing, and they were more willing to be like, yeah, that sounds like a good idea. So we're like, let's just put the most interesting case in here so that you can get all this clinical data. Then you can read a case about it. And, I've heard from a lot of people that they were like, that was really, really helpful.
Yeah.
As a new clinician, like I used to love reading case reports and just seeing the nitty gritty of like how and why things happened, because you don't always hear that or see that,
Like that flexion with medial carpal overpressure. That's interesting too. Like how, thinking about putting overpressure in just one different area so I think that's another good example of different things that you can try.
Definitely. So anyway, like the study says, to best illustrate an MDT extremity evaluation, we put this case report in here. And the patient was a 25-year-old male. He was an accountant, and he worked out at CrossFit. His symptoms: he had radial wrist pain, averaging on an MPRS 5 out of 10, and it was present for 2 weeks. So from our differential, 2-week time frame should exclude articular and contractile dysfunction. I think there's some debate now on how long contractile dysfunction can be around. I don't know if they talked about that at the CSU course, but at the time, that was what the book said, so that's what we referenced. But maybe there may have been some changes to that. I hope I don't get an email from the Institute still talking about it that way. So let's pretend it's 2017
Okay.
and I get in trouble. So yeah, symptoms were also intermittent. So from my perspective, that rules out inflammatory state. So 2 weeks, this guy does all this high velocity stuff. He could potentially have a reactive inflammatory state from trauma. He didn't say there was a trauma, but there's a lot of high velocity impact in this style of workout that potentially could have set that up. Or did he have a true tendonitis or inflammatory state of the tendon? So, from the intermittency of it, that didn't make sense to me. So, for the most part, we thought that it was highly unlikely that he had any sort of dysfunction or an inflammatory state, which made it highly likely that he had a derangement present. Without the trauma, again, he does some of these high intensity things. So, intermittency, I wouldn't expect some sort of structural compromise or stress fracture or something like that. And there was some variability within the things that were provocative. So sometimes certain things hurt, sometimes it didn't, which again, I don't think any of those things would be so inconsistent. That's, in my experience, more characteristic of a derangement. He reported that all these things in the workout that involve end range wrist extension make him worse. The thing that specifically worsened him was a handstand push-up. So he's upside down, his hands in full extension, and he's bearing all of his weight through it, trying to do a push-up upside down. So it's pretty much the most amount of force you could put through wrist extension, I think.
Yeah, I would agree with that.
He hadn't seen anyone else, so he hadn't sought out any other medical consultation or had any imaging, and he wasn't taking any pain meds. The other thing that kind of ruled out at least a contractile dysfunction and articular dysfunction, is other than the time frame, is that he could have symptoms that lingered afterward. So if he provoked it, he might then have constant pain for 20 minutes, but then it would go away. Which also, I think, once you kick someone into an inflammatory cascade, it takes a few days to resolve, not 20 minutes. So that also kind of makes sense that it's not a dysfunction. It's not, and I'm sure there's weird outliers that could act that way, but in general, from what I see, that's how that works. And I never really see postural syndrome in the periphery, and the variability of it with this gentleman and the lasting nature of it after kind of also rule that out. So basically, derangement or some other weird other that I was unable to classify are on the table. When we evaluated him, his most obstructive movement was wrist extension, and then painful movements were wrist flexion and supination, both at 7 out of 10. And then we used the handstand push-up as his baseline. So basically, you go, okay, let me see what you're talking about. Go do it. That's 7 out of 10. That's where it hurts in the range. Okay, got it. We're going to use that and see if we can change that. This isn't something I always do. Probably do it more in the spine than I do in the periphery. But because we suspected wrist extension to be his provocative movement, we tested that first, and that it was confirmed. A bunch of wrist extension made him worse. So we felt if your history suggestive extension makes you worse, testing it makes you worse. We're seeing this correlation of people that worsen for wrist extension have wrist flexion as their directional preference. Let's go ahead and test all forms of flexion and see what is the best. So we tested loaded wrist flexion, partially loaded wrist flexion, unloaded wrist flexion under traction, and wrist flexion under traction had the biggest reductive effect. And I believe it abolished all of his passive baselines. So flexion didn't hurt anymore, extension was restored, and supination still hurt, and the handstand push-up still hurt. So we prescribed a high frequency, 10 reps every 1 or 2 hours, and saw him again in 48 hours. So visit 2 is 48 hours. And I think another interesting thing is we didn't tell him not to do anything. We didn't restrict anything for him. He was motivated to keep working out. He was going to probably keep working out if I told him not to. But I find in a lot of people with peripheral derangements that it's a little different than the spine, in that, posture is so important. There's a lot of people with extremity derangements that I don't end up needing to say, don't do that movement. So we let him just continue to do everything that he wanted to do and just introduce this one variable. I guess if he didn't get better, we'd start to look at that given the high frequency of wrist extension at the gym. But I just thought that's kind of interesting and exciting for a young guy that wants to work out, or someone that's in athletics that wants to continue to play, or just anyone that doesn't want to have to restrict a bunch of stuff.
And I think what was interesting that he got better despite of keep doing his movements that would aggravate it. So
yeah. So we saw him in 48 hours, and he had a self-perceived improvement of 80%. So he had much less pain with all of the things that hurt before. All his baselines were better, and but he still had pain associated with the handstand push-up. And he still had pain with, flexion was not painful anymore, but supination still was. So we re-exhausted all flexion loading strategies. I probably overpressed him and just mobilized him to flexion, or just generated more force on my own. I don't think we did a high velocity whip into flexion. I think supination is just, it caters to that. Like, it has, I feel like, I guess you'll have to test it out, Mariana, and let me know if you start high velocity whipping people's wrists, if it's helpful.
I'm going to start trying those.
And there's no further effect. So supination didn't improve from more variations of flexion, or therapist generated overpressure. So at that point, I think the thought was, he still has this baseline in supination. We already know extension worsens him. There's tons of other movements that we can try, but let's just go into supination. We're seeing 50% of people get better with it so far, the most painful movement. So let's see what happens when we push into it. So just active supination with patient overpressure had no effect. So just him pushing in to supination didn't do anything. Kind of like the wrist flexion, we saw wrist flexion with under traction. He's a significant reductive force for a lot of our patients, and I see that a lot also in the clinic, excluding the study. So we thought, let's just traction and see what happens. So under traction, he didn't have pain when he was supinating, but there wasn't a carryover after. So all his baselines were exactly the same after performing more and more repetition of that. So we tried compressing him just to see, all right, if we get more load through this movement, or force through this movement, does that have any effect? And that didn't do anything. And that's where this weird movement we were talking about before came in. So let's just fiddle around with supination. And my first continuing education course I ever took was a Mulligan course. So
I was thinking about that. I was like, that looks like there's idea of.
Yeah, I tested a lot. Before being good at MDT, I used to use a lot of Mulligan techniques. So it's in my head, I guess, when things start to go a different way for me. And so a lot of the movements in MDT and Mulligan are similar in the lateral compression and rotational movements that we do with the hip and knee and things like that. But they use more accessory movements through movement, which is kind of where this came about. I'm like, there's something off with supination. Let's just see if we fiddle around the joint and apply an accessory glide if it does anything. So, this was published in 2017, so it was probably 2014 or 15 that I evaluated this patient. I'd have to look back. So I can't remember if I tested more and just excluded that from the dialogue. I think we just did this and it worked, so we ran with it. So the movement, and I'm going to read it because sometimes it's
confusing.
So we applied anterior force to the distal radius and posterior force to the first metacarpal during supination. So he applied, I did it initially, and then he applied the force on his own, and we just maintain that force into the motion and probably reset every few reps just to get more force on it if he lost.
Was the patient able to keep the pressure and do themselves?
Yeah, we sent him home doing that. He had that day that abolished pain with supination, and I think handstand push-up was still painful, but that was still the most reductive thing we had tried. And at that point, we exhausted all flexion. In the second visit, we had moved him into supination like 4 different ways. So we must have moved him like 200 different ways. So I think we're kind of at the end of we're getting a pretty good response here. Let's just call it a day and go test this, because you move someone 2,000 times, they're just going to get sore, and then you might get a false negative if you have the right movement, and they just can't even tell because you moved them too aggressively. And yeah, I guess he was able to, because he came back in a week for visit 3, 100% better, with no pain, no baselines. He was back to form with workouts. Handstand push-ups were fine. And then we did 1 month follow-up and 1 year follow-up, and he had no recurrence of symptoms, and was no longer feeling the need to do that movement. I forget exactly when he stopped. We did instruct him to prophylactically do it, especially if he was going to do more, or if he was going to continue to do that style of workout. Yeah. So I thought that was a really interesting patient. Just, differential is kind of interesting. The loading strategies are interesting. The anterior force to the distal radius and posterior force to the first metacarpal was new to me. I heard from a lot of people, they were like, I would never have thought to do that. That's super interesting. And I think it really just emphasizes, at this point, we already had him confirmed as a derangement, so maybe he just would have been someone that didn't get fully better. But if we didn't do that, we could have said, yeah, you no longer benefit from this. I can't help you. And that's really interesting to me. I wonder how many people did I never find the right movement on? Because this is such an obscure movement to me.
Yeah.
And why we wanted to put this kind of information out there, because, it gives more clinicians some different ideas, and you have a willingness to push it, try it, like your interesting loading strategy today, which I think is really cool.
Yeah, I mean, you just start to getting these ideas, and then, if that work, and then you just start to having a different rationale about the movements and trying different things that you never thought about, or like, if that direction worked, we can try the opposite too, and just having new possibilities. And I was like wondering where that came from. I was like, I did a Mulligan course as well. I was like, that makes sense. Yeah, so that was very cool. It's just a different strategy that it worked. It reduced. So
there's a similar actual Mulligan technique, but I don't think that's a formal Mulligan technique. But it's very along, their lines of like the finger example, where you do the alter or the lateral glide through a sagittal movement.
Yeah, so that's very cool. And again, we talked about that before, about having you showing the movements that were reductive. I think that's very helpful to get all these ideas. In this study, it was interesting. There was a lot of flexion opposed to extension. Yeah.
And it's interesting. I didn't really track it this way, but I felt that I extended a lot more wrist before this, and since this, I flexed way more wrist than I extend, actually.
Mm-hmm. Very interesting. Yeah, it would be cool to see like more cases showing the directional preference so people have better ideas like, well, that's been working for this person, so I'm going to start trying this too. So I think that's really helpful, very practical, as you said. So I think that's very beneficial for the clinicians.
Yeah, and really, if you think about those 4 factors, it's not that hard to track. If, any clinician was to say, I want to see if there's correlation in all my knees, because otherwise you don't think about it. I mean, you start to develop pattern recognition, but this study in particular really got me to think different. Maybe not not even that much differently, but more efficiently about how to get there. Because I mean, those factors were things that I came up with because they're things I think about when moving someone or testing someone. But yeah, just to have the confidence, like, there is an association with a lot of this, allowed me to definitely get better outcomes.
Yep. And I think another thing that was very interesting, I think you mentioned about the lack of association with the obstructed movement, which and painful, which sometimes we get a little.
It's not what I thought it would be. I thought it would be the opposite of that. And it was less, at least the painful correlation was less in the global extremity study that we did. It was only like 33%. But in this one, it was really high. The obstructed movement was similar, which is interesting. Because again, anecdotally, I see a lot of extremity problems that the most obstructive movement is directional preference. But yeah.
It's just something to think about. Don't go necessarily for the obstruct movement, but for looking at the mechanical stress, maybe more relevant than thinking about the obstruct movement.
Absolutely.
Very cool. Very cool.
Yeah, and I think that is I think that's the bulk of what I had here. Kind of the discussion we talked about, and there's a few different paragraphs that touches on why that learning curve might be there. We kind of already talked about that with the lower prevalence and just the different correlations with obstructive movement and all that. And then, I referred back to the lumbar spine for this mechanical stress idea, because that's something we think about all the time. Talk about all the time. People that slump a lot and bend a lot, thousands of times a day, they need to extend usually.
Yeah.
And that's easy. You get you get that in someone's history, it makes sense, and it usually works. You start to connect that to peripheral joints, and I find it's similar. It usually works.
Yeah.
So it's not that new. We just haven't applied it in words.
And just having that structure really helps, and being able to reference that really helps. So
I think we hit all the highlights and more. So I don't know if I have any other stuff for you, unless you have any questions.
No, I think we talked about all the points that I wrote down here to ask you. So I think that's very helpful. I'm not going to ask you all the same final questions we've done before. So if people want to know about your favorite resource of information, advice, they can look on the previous episode.
Thank you. I probably would end up saying totally different things, and then I'd listen to it later, and I'd be like,
well, I changed my mind. That's not really the best advice I can give. So Joe, I really appreciate you coming here again to discuss with us this paper. I think it was very, very helpful. All these different ideas and directions, and confirm the same rationale that we talked before about the mechanical stress, and what to look for first, what to try first, and then if you get stuck, different ideas. So thank you so much for doing this research and dedicating your time and all effort to make this happen and help us have more structured ways of assessing, treating, and giving different ideas of reductive forces and directions and loads. So that was really helpful. Thank you so much.
You're very welcome. It was my pleasure. Oh, and I did want to say one more thing. for anyone that is interested, because a lot of people don't read research the way that you seem to be passionate about, or maybe skim it, to get this information more out there to a larger sample of people. We have two different YouTube clips or videos that one reviews the study and one is our presentation of this in Miami, which is kind of a reiteration of this. So if anyone's interested, if you just go on YouTube and put in Maccio physical therapy, you'll see a whole bunch of videos. And I think that's also almost equally helpful to, it's more likely that someone's going to view that and read my whole paper. So we wanted that we didn't want to have it get lost in the shuffle. And so I think that was a helpful way to do so.
Absolutely. I'm going to put that on the show notes. So people, if they want to find the link, just go there and click, and it's very practical. You can just have a quick overview and get update on what's going on.
Perfect. Thank you for doing so.
Thank you.